Hi, everyone. Thank you for joining us for today's session. We're going to give it a minute before we get started to let a few folks trickle in. I think we can get started. Welcome, everyone, to the 2026 Digital Health Summit brought to you by the California Telehealth Resource Center. As you know, the theme of today's event is Bridging the Gap, Digital Health and AI for Smarter Care, Stronger Teams, and Sustainable Healthcare. We're so glad to have you guys join us today for today's session, From Innovation to Sustainability, Payment and Policy Pathways that Make Digital Care Scalable. I'm Jan, and I will be your moderator for today's session. As a disclaimer, the session is purely for informational purposes. The California Telehealth Resource Center has no relevant financial interest, arrangement, or affiliation with any of the organizations related to commercial products or services discussed during the summit. And as a quick reminder, you will need to register for each session to join. If you haven't already, it's not too late. We'll share the registration link in this chat. Thank you, Crystal. There's still time to sign up. So we hope to see you for our remaining sessions. And we are on the Teams platform today, so I'd like to go over a few tips to help you navigate the summit successfully. You can use the Microsoft Teams functions here to open the chat, to ask questions, post your comments. You can also send a reaction and connect with your fellow attendees and interact in today's session. We're also holding the last few minutes of today's session for Q&A, so encourage both presenters and attendees to keep the conversation going on in the Teams platform. We are recording today's session, and that will be posted on the YouTube channel for CTRC. Please keep an eye out for announcements when the recordings are available. And if you have any technical issues, please reach out to a member of the CTRC team on the platform or contact us at caltrc@ochin.org. Next slide, please. And then the work that we do at CTRC would not be possible without the funding and support from the Health Resources and Services Administration Office for the Advancement of Telehealth and the California State Office of Rural Health, part of the Department of Healthcare Access and Information. Next slide, please. Now I'd like to introduce our amazing speakers today. First up, we have Chris Adamek, the Executive Director of the Alliance for Connected Care, an organization dedicated to ensuring that all patients can realize the benefits of connected care. Chris brings 15 years of experience elevating clinicians, patients, caregivers, and organizations to implement federal policymakers and advance health policy change. Previously, he's held policy leadership roles at the Primary Care Collaborative and the Healthcare Leadership Council, working to convene leaders from all sectors of healthcare to build consensus for multi-stakeholder policy advocacy on a broad range of issues. Chris has also previously worked for a leading patient organization on Capitol Hill, the state of Michigan, and in political campaigns. Next, we have Rebecca Guilt, the founder of Elevare Law, which she launched to redefine legal partnerships for healthcare and technology innovators. Rebecca has more than a decade of experience advising digital health, AI, and virtual companies, bringing deep regulatory expertise and a practical business-first approach. She previously co-founded and led the country's first boutique healthcare innovation law firm for over a decade, guiding hundreds of companies through complex regulatory landscapes, helping them pivot, scale, innovate, and succeed, and has also worked with the U.S. Department of Health and Human Services on Affordable Care Act implementation. We're grateful to have both Rebecca and Chris join us today with their perspectives to this conversation. Before we dive into content, I'd like to ask, if you're coming in, if you can make sure that you have a chance to mute so we can hear our presenters. But before we dive into their content, I'd love to set the stage for us. So there's a big theme here, and I think that is that digital health is no longer something that's nice to have or happening on the side. It's becoming a part of how care is structured and delivered. But just because you have a service that works in a pilot, it doesn't mean that it's going to be sustainable in the long term. You have a policy and payment environment that's moving really quickly, especially around telehealth, RPM, RTM, AI, and other technology-supported care. So organizations need to be thinking ahead about what they're building, why they're building it, and how they're going to keep it going. And for rural providers, that's especially true. You have new funding opportunities like the Rural Health Transformation Program that can help create momentum with that initial startup funding, but they don't replace the need for plans. So the question is not should we use more technology, but rather which digital services actually fit our patients, our workflow, our payment pathways, and our workforce. So today's session is meant to help separate what's becoming more durable from what is in flux. So with that said, Rebecca, the floor is yours.
Hi, everyone. Thank you so much for CTRC for having me here. This is a couple of years into doing these things, and I love the organization and supporting it. I won't spend any time on my introduction because we have a very short amount of time and big topics to cover. I want to talk about three things today. The first is the sort of federal landscape, the sort of flexibilities and the patchwork between federal and the state governments, the tension that exists there. The second is two particular programs, the CMS Access Program and the FDA Tempo Program. And then I'm going to talk a little bit about what these sort of shifting policy and program changes mean for you. And, depending on whether you're a buyer or a seller or a patient, et cetera. All right. So the current landscape. Most of you are probably aware that Washington has been, during this administration signaling a lot of flexibility on regulation. A lot of that is happening by executive order. A lot of federal policy coming out of the White House and from the agencies. So we're seeing a real push to clear AI-enabled devices. More than, I think now it's more than maybe 1,400, which is more than double the rate that was happening in 2022. And we're seeing, and we'll talk about a little bit today, the kinds of programs that are continuing to push beyond fee-for-service. And we're not going to talk about today, but the WISER program that's also sort of explicitly using AI inside the payment system itself. So federal policy is like, let's expand, let's create flexibility, let's see what the possibilities are. We're in a global race to own, the best technology. Let's see what's out there, and the balance of the balance of the gates that prevent technology from making it to market have shifted toward innovation. I think, though, if you were to ask me where to pay attention to AI policy right now, I would say it should be at the state level. Federal, it is the desire of many at the federal level to supplant state level, varying state level laws with sort of a federal standard. There are constitutional problems with that. There are process problems with that. And of course, it's got to go through Congress. So while that is being hashed out, the states are moving. And there's sort of four fronts that I've identified that are sort of moving at once. The first is outright limits on AI and clinical and coverage decisions. The second is, and more popular, more common, are patient-facing disclosure rules in several states. These are regulatory language saying you've got to tell people when AI is being used for this, that, or the other. The third, and sort of the most popular in the press right now, is state legislation on mental health and companion chatbots. Illinois has an outright AI therapy banned. Nevada and Utah are regulating mental health chatbots. California has a companion chatbot law. Lots of other states are working on it. And I actually read this morning that there's a bill in Congress. This has obviously been an area that has spooked a lot of folks. And so we're seeing a lot of legislation. And then the last are sort of the consumer protection and anti-bias laws. Those include the Colorado AI Act, which was set to go into effect this summer, but has been suspended and revised and narrowed and probably won't go into effect till next year. These are under attack. These AI anti-bias laws are under attack as part of the broader sort of anti-DEI movement at the federal level. And you're seeing some of that at the state level as well. But there are bills running through Congress who are specifically just talking about consumer protection in general around AI, and they tend to have language that separate sort of riskier AI use cases from less risky. So there are specific things around healthcare and insurance in several of these bills. All right, so states. So that's sort of the general AI policy that I can get to in a 15-minute conversation. If you want to talk to me about it, follow me on LinkedIn or follow up with me after. But the two programs I want to talk to you about at the federal level are the CMS Access Program, which is really a new way to get paid, that healthcare gets paid for, and the Tempo program, which really changes how innovative healthcare devices get to market. So let's start with the CMS Access Program, Jan. All right, so the Access Program. This is, like many federal programs, it's an acronym, the Advancing Chronic Care and with Effective Scalable Solutions Access. This is a voluntary 10-year Medicare model out of CMMI that pays for, that attempts to pay for outcomes instead of visit volume. So, you know, what's most important now is sort of the general structure, and keep in mind that this is the first year, it's almost here. We haven't even hit the first month of the program going live. It's intended to go for a long time. I'll circle back about why that's important in a little bit. The folks that have signed up to be Access participants are locked in now. There are, for those of you who are interested, there are rolling applications for future cohorts, but the future cohorts, I believe, will start in January of 2027. So there's 150 organizations that have signed on. A lot of those organizations have never served Medicare beneficiaries before. I'm sure that's a feather in the cap of the policymakers who really want to bring in new entrants, new innovative entrants into the Medicare space. The relevant players are fee-for-service and Medicare beneficiaries. This program can be duplicated, was built to be duplicated for Medicaid, for the commercial space, but Access itself is just for fee-for-service Medicare beneficiaries and Medicare enrolled providers who are working with an Access participant. So those 150 folks. And the important thing about why this is different, why this is a signal about federal policy for how healthcare gets paid for, is that this is an outcomes-based program. So it is deliberately built to bring in tech-enabled players into Medicare, and it was built for a model of care that is not based in how many fee-for-service E&M visits that a person has. Let's go to there we go. All right, so in the Access program, there are 4 clinical tracks. And these clinical tracks were chosen because these are hugely expensive conditions. I believe these 4 conditions make up cover about 2/3 of Medicare beneficiaries. And each one of these is paid on standard validated measures. The early cardio-kidney metabolic, and behavioral health and musculoskeletal shouldn't be surprising. These are, like I said, these are quite expensive. The idea here is that folks would be paying for the ongoing care of these chronically ill folks and would be paid based on certain metrics around how these folks, basic health and basic sort of measurements are improving or not improving. So the money, yes. Okay. So here's, yeah, I agree, Dr. Nasir. Yeah, so here's the problem with access. It sounds really, really great. And I wanna take you back to 2019 for those of you, I'm not gonna step on my co-presenter's toes, but back in 2019, we also saw new exciting codes, RPM codes, that paid very little, only permitted physicians to bill them. It was a structure that failed miserably, and then in ensuing years improved upon itself, became more compatible with building businesses around it, and became a multi-billion-dollar industry. So keep that in mind when you're watching Access. This is the first, this is the opening salvo of the next 10 years of this program. Right now, the payments are modest. They are so modest that some folks that are big in the musculoskeletal space, for instance, I'm sure you could guess the names of these, they've decided to just not even get into it. They've run the numbers. They said it's not worth it. They're not interested. So right now, Access does pay less than today's available codes for similar conditions. Pays less than RPM, pays less than CCM. My impression is that that they're starting low to see what kind of innovation that this spurs, and then they're going to listen to the industry, and they're going to make changes, based on that feedback. That's exactly what happened with the RPM program, which of course now includes RTM and PCM and TCM and all these things. So keep your voices loud around this if you think that this is a model that's going to work. The CMMI's track record has not been great with their innovation programs. So I think that might be sort of another piece of why this is coming in a little bit lower. So I think I missed a slide, Jan. Can you go back to the how the money works slide? Yes. Okay. Yeah. Yes, that one. That one. Okay. So just to reset. So here the money works. Okay. So the main flow is payment to the organization that's doing that's doing the chronic care management. The allowed amount is structured, 80% Medicare, 20% coinsurance, and there are ways that you can sort of waive those things. There's rural add-ons for the cardiometabolic tracks, et cetera. These fees are paid monthly at 1/12 of the Medicare portion, capped at 50% during the year. The other half is withheld, reconciled after a full 12 months of care. So half of these payments are at risk until you have proven outcomes. There are two thresholds that you've got to clear. So there's the clinical outcome threshold. You get the full payment if at least 50% of your patients meet all their targets. And then there's the other threshold where you have to prove that 90% of patients have avoided duplicative services elsewhere. So these targets are really sort of improvement-based, measured from each patient's baseline. The other smaller part of this is that the patient's regular clinician that refers into the access participant, that clinician can get a co-management fee for reviewing and coordinating the care of the patient that the referred access participant is treating. So there are a number of people sort of in this cycle, and I think the idea is they're trying to make sure that primary care is still at the center of this, but that there is someone that's looking at sort of the ongoing chronic care, and they're integrating technology into this to keep costs low. Okay, let's skip down to Tempo. Sorry, I know we're running behind. Okay, Tempo is a small pilot that lets sort of a select amount of, here, let's skip through because we're going too long. Tempo is a small pilot. Let's select a select set of digital health devices deploy inside Access before they're authorized. So there's a small number of folks that are participating in the Tempo program. It's tiny. It's only going to allow 10 manufacturers in each of those 4 clinical areas inside of Access. And basically, the FDA is going to exercise enforcement discretion on certain pre-market authorization rules for those technology companies. I do not believe they've had enough to publish that they have all 10 Tempo participants yet. And there are strings attached. So you have to collect real world data, intended use. You've got to pursue full marketing authorization eventually. But basically, what the providers in the room need to know is that there's a glide path for those devices, but these are not cleared devices. And for the folks that are selling in the room, this expands FDA's enforcement discretion, which has been expanding already through renewed guidance this year. So again, these are signals about what the federal government intends to do on sort of new payment models and sort of creating these pathways for companies to use technology to expand access to patients. All right, so practically, can you go back one more? All right, so just a couple of things. If you're a referring provider, what you're going to do is you're going to refer out your patients to an Access participant, co-manage them. If you're an Access participant, you're going to take on the risk by managing the chronic care of the patients, and figuring out how to do that at a price point that makes sense. And if you're sort of building one of these companies, you're not going to be able to bill Access directly, but there are a number of interesting business models that I'm starting to see tech companies take on in partnership with other folks in sort of the ecosystem, the referring provider and the Access participant. So anyway, I left a bunch of URLs for you to get other primary sources. Really appreciate the time, and I'll cede the remaining time to my co-presenters.
Chris, you're up next. We'll give you the remaining of the time until the 40 mark and then go from there.
Awesome. My name is Chris Adamick. I serve as the Executive Director of the Alliance for Connected Care, a national advocacy organization leading on telehealth, RPM, AI-enabled care. On the next slide, I outline a little bit more about what we do. We have 3 buckets of work. We resolve the permanency challenges in current virtual care delivery. We break down payment and regulatory barriers to digital health expansion, and we are working to shape the evolution of AI-enabled care, which we view as a natural extension of our more than 15 years in digital health advocacy. I'm sure many of you have signed our various sign-on letters over the years, and I'll flag for those of you who might have seen, we also have a current pledge for organizations that are committed to educating policymakers about the importance of permanent telehealth as we come into this fall cycle. Moving here, I'm going to start with our dashboard, and this is a little complex, but this is just this is our post-pandemic snapshot of what we had, what we've won on, what remains in play. I'll come back to each of these issues individually, but still like to think about it in this broader context. So I'm sure folks will like this chart, but move along. Just recapping really quickly, some of the things that we all know. Medicare telehealth extended until the end of 2027, however, still unstable. And for all of the things we're talking about today, I don't think it can be stated clearly enough that it is not okay to have a unstable digital health foundation under all of the other services that we want to provide. Do RPM, do AI-enabled care work without telehealth alongside? That is a question. And so I do think that this permanency is necessary, and it is necessary for a lot of the innovation and change that we want to see moving forward. I don't need to talk about what those individual flexibilities were, but they're still not permanent, and that's an important detail. If you can jump ahead. One important thing that was included in the Medicare telehealth extension this spring that everyone should know is that there will be payment modifiers on telehealth services when they are provided through a virtual platform. What that actually means will be defined probably in the fee schedule in a couple of weeks and will go into effect in 2027. So that is a change that people will need to make this year. We've pushed back on this provision quite a bit. My understanding is that there was some concern about utilization from fully virtual providers that led to this. However, the language you see on your screen implicates most telehealth providers because most interact with some sort of virtual platform. And I do think that this differentiation is problematic as we look at Medicare payment for telehealth long term. I would hate to see us define this population inappropriately and then use a payment modifier for something other than data collection and learning. If you could move forward. Also want to flag a major development happening this year. Last summer, we made permanent commercial market telehealth flexibility. I think a lot of employers and health plans weren't able to fully put that into effect for 2026 just due to lead time, but I do expect we will continue to see more flexibility for pre-deductible telehealth coverage following that flexibility last year. So another big win that is, I think, still percolating. Move forward. Other things I wanted to flag from the legislative package at the beginning of this year that are new policy changes that are going into effect. Obviously, acute hospital care at home extended for 5 years. We have added in-home cardiac rehab flexibility, and that is specifically extra flexibility for that to be facility billed cardiac rehab services, which are reimbursed at a slightly higher rate. We have both regulatory and statutory expansions of virtual diabetes prevention programs. And that's actually new, not something that we even managed to turn on during the pandemic, but a lot more flexibility for these programs to be used virtually and reach patients virtually and support diabetes prevention programs broadly. A last one I wanted to flag here is we will soon see additional guidance on furnishing telehealth to individuals with limited English proficiency. And then just to recap, we're coming into the fee schedule. We'll see the Medicare fee schedule in just a couple of weeks here. But recapping the major things that happened last year and that you may still be implementing this year. One of the biggest wins for us was flexibility for provider location reporting. And so this is often thought of as kind of the home address reporting issue for telehealth providers in Medicare. That was not in the rulemakings last year. We ended up getting sub-regulatory guidance at the end of the year last year, allowing additional flexibility for practitioners to offer a telehealth service and not report that location if they're offering it from their home or another location. I do want to flag for folks that may not be paying close attention that there's been continued movement in this space. So there is now relatively detailed implementation guidance from Novitas and some of the other MACs that outlines flexibility for providers to assign their billing to a in-person facility that could even be out of state from where they are located and report their telehealth services from that location without ever having to report their home address or another location that they're offering services. So like we've continued to generate some progress on the regulatory front here for flexibility. There is still a challenge for fully virtual providers who have no kind of in-person footprint or presence to point to for those services, but we've largely addressed the concerns for any provider that does have a physical practice location. Another big one last year was virtual work for teaching physicians, a little flexibility. Obviously, we need to train the future doctors to use telehealth or other clinicians. And so this is an important flexibility for Medicare. We also dramatically expanded virtual direct supervision for Incident 2 services and others. Smaller wins. The Medicare telehealth services list is now more flexible than it used to be. One of our longstanding complaints was this idea that you needed to prove a service was valuable in order to add it to the telehealth service list. And so you need to prove it was valuable and prove it was appropriate for telehealth. They modified that last year to just say prove it was appropriate for telehealth if it's already a proven service. That feels really basic, but it does lower the threshold for adding additional telehealth services, and so that's meaningful. I already talked about Medicare diabetes program expansion. There were some frequency limitations on codes that were removed, and I will talk about RPM more. Next slide. One interesting development recently that I wanted to flag for this group is just late in May, CMS announced a billing change for FQHCs and RHCs, billing telehealth services. So asking them to start submitting HCPCS codes in October. And so this is not the full win that this community is looking for, because it is not changing their payment rates, but it is a step towards billing in a way that is more aligned and resembles fee-for-service more. So flagging that for anybody who is paying attention. Congress has to fully fix this, but CMS is taking steps. One of the biggest and most concerning outstanding virtual care flexibilities I want to flag is still DEA regulation and controlled substance prescribing, which is crucial to many telehealth visits. We have an expiration at the end of this year. It is sooner than most of the other expirations. There continues to be not a lot of transparency from the DEA on its path moving forward here. We continue to be in a place where we have temporary extensions rather than long-term policy with clear guidelines and guardrails and program requirements. I think the community would be well served by a permanent policy, even if it had some additional guardrails in place. But it has been a struggle to get the DEA to move forward with that. I have heard that they are working on a final rule. They've said that, but generally provide very little information publicly. So we continue to maintain pressure. And I do think it is important for all policymakers to understand that this is probably the telehealth piece that breaks first, or is most likely to break. Last year, they extended it with 2 days left before it expired. And so does continue to be a source of concern for the community. Next. Okay, to jump in on RPM in a little bit more detail, last year was a really big year for RPM. We added a couple of new codes. We significantly increased reimbursement. One of the outstanding challenges is that we found a reimbursement structure for the RPM supply code that involved crosswalking payment from the hospital payment rule, which is a great patch, but is not a long-term effective evaluation of what those services cost and what they should look like. So there's a little bit of instability there. Have been working with policymakers to ask them to build something more sustainable and accurate long-term. So that is a noticeable thing that I'm hoping to see progress on in the fee schedule shortly. There's still remains some churn in the RPM program. The codes don't fully capture the costs of providing those services for many providers today. Just the benefit of not having seen how care would transform over even just the few years that RPM has existed. So I mean that to reflect things like software costs and other capabilities that RPM companies today often entail. There does continue to be some policymaker pushback on the growth of RPM, particularly in Medicare. There have been some concerns about misbilling of RPM, and some of those are inaccurate from OIG and reflect a lack of nuance in the kind of the provider conditions in offering those services. But there has been some concern about misbilling. And then finally, as many of you know, there has been some pushback from payers, United in particular, around around RPM coverage and the conditions for which RPM should be provided. That remains an active conversation as we see more and more publications around cost outcomes and quality outcomes from RPM that many are showing positive results, some are questioning, but I do think there's an active place there where we are seeing payers think about how they want to scope coverage for RPM and try to scope it appropriately. I've already mentioned the PFS is coming shortly. Clearly, as we touched on before, the access and tempo models do relate to RPM. I like to think of access as a vision and what CMS likes to think of the future as. I could easily see access being a vision for what RPM could become at some point in the future. Obviously, that's probably not appropriate for all the services that RPM is provided for, but there is definitely some overlap. And I also think that one of the paths forward here to that point is the further expansion of AI-enabled care management and RPM programs. That is something that is on the horizon at some point. I don't know if it's this year or in the future, but it's something that I do expect we'll see. If you could take another step forward. I'm really quickly, just since we're talking about AI here, when we think about AI, I structure it in this way. AI should strengthen clinical relationships. AI should be a natural, and I mean AI-driven care. Should be an evolution of care. It's not a new and innovative treatment. It is a way to support services and treatments that are already being provided and allow them to be made more efficiently and effectively. It does rely on resolving some of the barriers we've already talked about. The path forward, in my view, is pursuing regulatory and reimbursement changes that are open-ended and modality agnostic. We need to give clinicians the flexibility to use the right tool for the right patient in the right moment. We have some places like time-based reimbursement for clinicians that does create barriers to deploying more tools in the delivery of care. As we have talked about in the access model and other places, outcome-based models are the place where that can accelerate most quickly. And then finally, we will need some regulatory frameworks that support this care. Next. Okay, I want to talk about the Rural Health Transformation Program a little bit. I don't believe I need to get into this slide too much because most of you know what the Rural Health Transformation Program is and looks like at this point. And so on this first slide, I think the only point I really want to make is that states are required to meet ongoing reporting and monitoring requirements tied to outcomes and measurable performance. This matters. CMS can take the money back. And in a state like California, I would assume that there will be aggressive oversight from the federal government to make sure those dollars are spent well. So states need to be intentional in developing outcomes and metrics. I do think that there is a challenge in the expansion of these programs that is driving digital health adoption. Actually, if you can keep moving, I want to drive forward a little bit. And I think the thing that is driving digital health adoption is a lot of incentives from CMS, but also I think that the need to capture a lot of data around the transformations that are happening lends itself well to digital health interventions, simply because technology-driven solutions are going to have an easier time capturing data, not creating a whole bunch of provider burden in capturing what the interventions are doing and how they're working, given that reporting is such an important part of the program. So we understand that CMS and states are moving forward. We understand that we're going to see a pretty rapid timeline for things happening this summer. We're going to see 2026 funds allocated soon. I'll note that California in particular, I think you have legislation that will enable the program happening soon. But then California is going to have to move very quickly. The first reporting to CMS is due in August. That reporting will require California to show progress to the federal government. And what that's going to mean is it's going to create an incentive for off-the-shelf, easy to implement solutions, just because there will be a strong need to show outcomes, and on a very short timeline, or show progress at least. So we'll see that reporting deadline in August. We will then start work on there will be another round of funding that follows for the year after that. If you could move ahead. Broadly on digital health in the Rural Health Transformation Program, to the point before about it being prevalent, that's part by design from CMS, but also the results here are clear. Every state is expanding telehealth through Rural Health Transformation funding. Many are doing other things. I think I'm close to the end. I have one more. Oh, last I wanted to touch on Rural Health Catalyst Funds, which is an interesting subcomponent of the Rural Health Transformation Program. And so that is just 7 states at this point, but those states are having funds that can support the development of companies that are small, less than 10 years and less than $50 million in funding. Those funds are intended to support consumer innovations, and I've described what those are here. So we have these 7 states that are doing stuff. There are other states that are thinking about similar things that are less constrained by federal requirements, but there is this kind of interesting thread around what kind of local innovations can be driven up and scaled through this fund. And I think that's something that is underappreciated in the broader conversation around it. Okay, I'm just 1 minute over, I believe, of the time you've allotted me.
Keep going. Alrighty. Well, thank you so much, Chris and Rebecca, for such a wealth of information. I know the chat was popping. But I do have one question, I think, from Dr. Nasir. She had a question about, do you guys support guidance for telemedicine, only addiction treatment and chronic care management practices, no brick and mortar?
I'm not sure I understood that. Do you support
Dr.
it
Nasir,
like
feel free
politically
to.
or from a implementation standpoint? What is that?
Dr. Nasir, feel free to jump off of mute, but it's one of the questions I wanted to block in the chat. But I'm wondering if it's more
Thank
about.
you. Can
Oh,
can
yes,
I
perfect.
ask?
Yeah.
Hi, thank you so much. No, I'm just curious. I'm trying to open up a purely telemedicine only practice, and I'm just trying to, this is going to be a solo practice. I'm not very familiar with the rules and regulations, so I was asking, do you guys have like a advice or like a checklist on the things that private practitioners can do to make sure we're compliant and we're not kind of going off into the deep end and attracting the wrong attention?
And it looks like CTRC stuck some things in the chat here, which could be useful for you. I will flag from a federal level, the ability to do that work through purely telehealth is subject to DEA regulation. I think that's the big risk for you opening work like that if you wanted to do a lot of telehealth.
Yeah, I would also check out the American Telemedicine Association. They have a number of good guidance resources, and also the American Medical Association has telemedicine specific guidance. It depends, if you're doing addiction treatment where you're prescribing controlled substances, you're going to have an issue with DEA. If you're not, then,
No, I will be at least like, buprenorphine and the basic, not the methadone. So I'm just trying to make sure that I'm like following the proper rules and what are the rules to watch out for. I appreciate the list and thank you.
Okay, I think, yeah, we're going to wrap it up. We have a minute left, so I want to
Mm.
make sure you guys can get to the resources that the CTRC offers. So for ongoing support, make sure you connect with our website at CalTRC. You'll find more events like this, webinars, on-demand resources, and more, very similar to what was posted in the chat.
Mm.
And then up next, we also have our 2026 AI cohort. This builds on the foundation and success of our bootcamp from last year. This is a no-cost virtual cohort designed to support healthcare organizations in exploring and advancing use of AI in a way that is practical, responsible, and aligned with real-world care delivery. So as part of today's summit, you have the opportunity to complete the first 3 sessions of the cohort series, and we'll continue the series with 3 additional sessions offered later this summer in July and August. To learn more, we have the link in chat, and you also have the QR code here. And then we'll also be putting a poll. We encourage you to please take the time to complete the exit survey. We want to make sure we're meeting your needs. If you have any feedback or ideas, please feel free to let us know via the survey, and we'll leave that on open for a little bit longer. But we also have some QR codes here to stay connected with CTRC. So our social media and our website here. And the best way to stay in the know is to subscribe to our monthly newsletter. That's the first QR code right there to receive the latest updates on all available training, webinars, and on-demand resources. And a very big thank you again for Chris and Rebecca for their time and for sharing this wealth of information with us. So we hope to see you in our next session.
Thank you.
Thank you both.